Well, good evening, everyone. We'll go and get started now that it's 7:30 Eastern time. Thank you all, thank you everyone for joining this evening. We're very excited to host tonight's Journal Club. So first off, my name is Josh Romero. I'm a current sports medicine fellow at Mayo Clinic in Rochester, Minnesota. I completed both my intern year as well as my PNR residency at Mayo Clinic in Rochester. And after this, I'll be staying on staff in the Division of Sports Medicine at Mayo Clinic. I was fortunate to be part of the AMSSM Sports Medicine Resident Council as a resident as the president 2 years ago. And as part of that, we were, me and another part of that group, we helped to create this journal club initially. And so I'm really excited to see that this initiative is still ongoing. And it's been really quite successful and allowed for a lot of residents and medical students to be involved in sports medicine and scholarly activity. So as similar to the previous presentations, really the goal of the AMSSM Journal Club is to provide a national platform for both student and resident members to present an article from the list of the top 120 articles that sports medicine fellows should be familiar with. Really, our intent is to make this a fun learning experience and to give medical students and residents mentoring opportunities with other AMSSM members while developing the skills of reviewing articles and making PowerPoint presentations. Normally we have 3 presentations, but tonight we're going to have 2 presentations for tonight's Journal Club. The format for the Journal Club meeting is that each presenter will have approximately a 20-minute block of time, and that after there will follow a brief question and answer segment after their presentation. So I would encourage all those attending tonight's session to please use the chat function during each presentation, and we will address those questions during the Q&A session after each presentation. I have the pleasure of introducing our first presenter, Dr. Hamilton Newhart, and then his club mentor, Dr. Alexander Porter. Dr. Hamilton Newhart is a third-year family medicine resident at the Baptist Health, University of Arkansas for Medical Sciences residency in North Little Rock, Arkansas. He is passionate about the field of sports medicine, and he has an interest in sports cardiology, particularly cardiovascular changes of the athlete. He hopes to begin a fellowship in the coming year, so good luck to him as match days now in 2 days. He enjoys board games, cooking Italian cuisine, and smoking meats. His presentation is on the article, Trends in Cardiovascular Medicine. I'd also like to thank Dr. Alexander Porter for serving as club mentor. Dr. Alexander Porter is currently a primary care sports medicine fellow at Wellspin Health in York, Pennsylvania. He completed his residency training at Latrobe Hospital Family Medicine Residency Program. Previously, he attended the Lake Erie College of Osteopathic Medicine, and as well as the Allegheny College for Medical School and undergraduate, respectively. He enjoys covering football, soccer, wrestling, and the Special Olympic events. Without further ado, Dr. Newhart, please take it over.
All right, well, I appreciate that introduction, Dr. Romero. With that being said, we'll just go ahead and get started. So the article I'll be discussing tonight is a review paper from Drs. Kovacs and Bagish from 2016, published in the Trends in Cardiovascular Medicine, which I'm sure many of you may have read in preparation for tonight. I have no relevant financial disclosures. I have several learning objectives I hope to get across tonight. First being to understand normal adaptive cardiac physiology in response to exercise. Also, I want to highlight how type of exercise affects its adaptation. Third, I want you to be able to roughly classify sport based on cardiac stress. And then lastly, I want to explore the very basics of pathologic adaptation. All right, so why is this relevant? Well, I believe this topic is highly relevant for primary care and sports medicine, as we're often one of the first-line providers for these patients. There are currently estimated millions of athletes, about 44 million in youth, 10 million at the collegiate and high school level, over 500,000 marathoners, as well as an increasing number of older athletes over the age of 35. So an older athletic population than maybe previously. Also, congenital heart disease is more common in adults now, as we have improved our ability to take care of these patients when they're younger. It goes without saying that there's obviously going to be significant physiologic changes that occur with exercise, and we'll be exploring some of those tonight. There's also quite a bit of overlap between normal adaptive changes versus pathology. For example, left ventricular hypertrophy of training versus hypertrophic cardiomyopathy, right ventricular enlargement versus arrhythmogenic right ventricular cardiomyopathy, and those are just a couple examples of where findings may overlap. Lastly, having a sound understanding of this topic can assist with return to play decisions. So to get started, we'll look at the very basics of exercise physiology. I think the key principle is realizing that the cardiovascular system must meet the bodily oxygen demand during exercise, namely that of the skeletal muscle. And this is going to be mediated in large part by the sympathetic stimulation of the heart. And there's several levers that the body can pull, such as heart rate, ventricular stroke volume, and peripheral artery vasodilation. Think back to medical school, we remember that equation, cardiac output equals stroke volume times heart rate. The second important topic is that the type of exercise itself matters. We'll be talking about two types of stress that exercise can exert on the heart, isotonic and isometric. Here's a well-known study from 1975 by Morgan Roth and others. Here they performed echocardiogram of 56 active collegiate athletes, and they were specifically looking at the left ventricular mass in these athletes versus non-athletes. And I think the key takeaway that I want to highlight here with this figure is that we've known for quite some time that hearts generally have to get bigger to accommodate the increased cardiac output necessary for exercise depending on the type of strain. The first type of stress I will discuss is isotonic stress. This is characterized by, quote, cardiac or cardio type exercise, which would include things such as long distance running and soccer. These types of exercise stress the heart with volume, which typically exerts its load on all four chambers of the heart, which is an important concept to understand. You'd also call this increased preload, and this is generally going to cause the heart to dilate and stretch, but more on this to come as we delve deeper into the topic. To highlight this concept of isotonic stress, I pulled this study by DeAndrea and others in 2002. In this study, they took 60 top-level endurance trained athletes and essentially tracked via echo how much end-diastolic volume was present in the left ventricle at the athlete's maximal workload effort in watts via the bicycle test. This is a very nice illustration, I believe, that clearly shows that as athletes' wattage increases on our x-axis, the volume of blood filling the left ventricle with each preload phase increases on the y-axis, which corresponds to this concept of isotonic stress that we're talking about. The second type of stress we'll discuss is isometric stress. I want you to think of this as short, intense bursts of high energy, i.e. our powerlifters or football linemen. This type of stress is characterized primarily by a massive spike in blood pressure, which tends to strain the left ventricle in relative isolation, as opposed to isotonic stress, which remember stresses all four chambers of the heart. This is a large transient increase in afterload that tends to cause left ventricular hypertrophy, similar to what we might see with some of our chronic hypertensives developing LVH for those of us in primary care medicine. To highlight this concept of blood pressure spikes, I pulled this study from Palatini and others in 1989. Here they took several bodybuilders and put them on continuous intra-arterial monitoring while exercising. The nice graph that I'm showing here shows a single athlete during a barbell squat exercise, which they actually found to be the most associated with blood pressure spikes. On the bottom, you can see that as the barbell is tracking up and down in height, we see massive spikes in the systolic blood pressure up to nearly 350 millimeters of mercury. And there's even some studies out there that you can find showing transient blood pressures up to 400 millimeters of mercury. All right, so now to get into a little more data, there's a number of papers that show how hearts respond to isotonic versus isometric stress, but I want to highlight this nice study from Dr. Bagish, one of our authors of this paper, a study that he did in 2008. Here they took 40 competitive endurance athletes and 24 competitive strength athletes, so not complete novices. They used an echo to look at various left ventricular data at baseline and after 90 days of intense team training. This graph in particular is looking at the change in the left ventricular mass on the x-axis over this time period compared to the change in the left ventricular end diastolic volume. So again, that preload or filling of the left ventricle. On the top graph, we can see that endurance athletes clearly have a strong correlation for increase in left ventricular dilation as a driver of the mass change, while the strength athletes actually remain the same or even slightly restricted due to the left ventricular hypertrophy with strength type exercise. We can see on the left-hand side of the screen, I've included some images to help understand what this study seems to illustrate. And as you can see, the endurance athletes on the top side seem to become dilated in their left ventricle, while the strength athletes tend to become hypertrophied in their left ventricle on the bottom side of that picture. This is now a continuation of the previous paper by Dr. Bagish, where now we're looking at the change in essentially the left ventricular thickness. Here they actually use the interventricular septal thickness plus posterior wall thickness as a measure of overall thickness. And again, this is 40 endurance athletes, 24 strength athletes after 90 days of team training. We essentially see the reverse of the previous graph, where now the strength athletes are showing a positive correlation with left ventricular wall thickness as a driver of the gain in mass, while the endurance athletes are staying the same. And again, I've included those images on the left-hand side, kind of as a visualization of what's happening. I believe this study nicely highlights some of these training-specific heart changes and the concepts of isotonic versus isometric stress, the endurance athletes being the isotonic side and the isometric being the strength side. But many other studies exist that show similar findings as well. To summarize a little bit, here's a nice figure from our journal club paper showing essentially what we've been talking about. Isotonic stress tends to dilate the heart, while isometric tends to thicken the left ventricle. The right side of this picture that I've circled here does show that this can potentially be reversed with periods of detraining, which we'll discuss later on in the presentation as well. Here's a chart put out by the American Heart Association in an attempt to classify sports based on what is termed dynamic and static strain on the heart, which correlates to isotonic and isometric respectively. Different terms for it. I am sure nearly all the fellows and many residents probably have seen similar charts before. When you're reading recommendations, you're often going to see sports referred to as Class 1A or 3C, and that's referring to this classification system. One thing I'd like to point out is that you also have to keep in mind sports with increased risk if a single pull event was to occur, and that's indicated by the sports with the cross. Obviously, having a syncopal event while rodeoing and riding a bull is much different than having a syncopal event while playing tennis or golf. So you have to consider that as well. As you can see, in reality, there's going to be overlap with most sports when it comes to isotonic versus isometric cardiac stress. So I think the next question that naturally flows here is how quickly do these adaptations happen? Well, there's a lack of complete evidence in literature, but there are several good studies looking into this, including the previous study by Dr. Bagish, where they saw changes in as soon as 90 days in those athletes. But I'll highlight one more study that Dr. Bagish was actually involved in as well. So the Harvard Athlete Initiative is one group that has looked into this. Weiner and others took men's freshman rowing students all over 18 years old and completed echo at baseline, 90 days, and 36 months after starting their intense rowing training. What they found is that in as soon as 90 days of intense exercise, the left ventricular end diastolic volume index, again, that filling of the left ventricle was statistically increased, and that was sustained throughout the 36-month period, which we can see on the left-hand graph. Interestingly, they found that the left ventricular wall thickness was actually unchanged at the 90-day time point, but there was a statistically increased left ventricular wall thickness at the 36-month time period shown on the right-hand side, which is very interesting, and I'll talk about that. This was a relatively small study, but interesting findings nonetheless. I believe they had 22 initially enrolled in the study, and then 12 completed the 36-month training period. This is another way of showing some of the same data from that same paper. I've highlighted some of the key takeaways I want to focus on with the red boxes. We can see once again that after 3 months, there's a statistically significant 11% increase in left ventricular end diastolic volume, but no change in wall thickness at that time point. Then when we change over to the 36-month time period, we see that the change in the wall thickness becomes more prominent, where now we can see a statistically significant 11% increase. So it seems that exercise-induced cardiac remodeling may follow a phasic response, the authors theorize in this paper, at least in this study population. And again, this was rowing athletes, and so it's a good mix of isotonic and isometric stress on the body. If we remember in that graph, it's actually in the 3C category on the classification of sport. So first, it seems like there may be an increase in the chamber volume, which happens a little more quickly, which is then followed by a chronic phase of increasing wall thickness. But overall, I believe this paper shows that adaptations tend to occur relatively quickly, and other papers would support this claim as well. The logical next step is to ask, can these findings be reversed with detraining, which is an interesting concept. There's a few studies that have looked at this, but there's a good study by Putukian and others in 2002 where they took 40 elite male athletes who had previously shown markedly increased left ventricular cavity and thickness, and then looked at them after a mean deconditioning period of 5.6 years, so pretty significant deconditioning period. They found that while the left ventricular thickness tended to resolve, the left ventricular dilation tended to lag behind. It was incomplete in most cases, and the dilation actually persisted in over 20% of athletes. This has also been documented elsewhere, and the clinical relevance of this phenomenon is debated, but it does seem like the stretch tends to be somewhat permanent based on these results. And then we have another study from Marin and Putukian and others back in 1993, where they took 6 elite athletes, and they found similar results, and they found that the detraining periods could be as short as 6 to 34 weeks. And other studies have shown similar findings as well, that some of these findings are reversible in relatively short time after detraining. Now we'll talk about electrophysiologic adaptations. Ultimately, it's a little beyond the scope of this talk to delve too far into ECGs in athletes, as this could be a whole talk itself, but I'd like to highlight at least a couple of things briefly. First, ECG correlates very well with structural adaptation, i.e. left ventricular hypertrophy, right ventricular hypertrophy, and atrial enlargement, making it a fairly good screening tool. Secondly, a key concept to understand is the effect of exercise on the autonomic nervous system. It causes a primarily increase in basal parasympathetic tone, which is where we get the sinus bradycardia and heart block. And this occurs as a compensatory response to the sympathetic stimulation that is induced through exercise. Here's a flow chart that I'm sure fellows have become very familiar with. It comes from Dr. Johnson and others, and it's the international criteria for ECG interpretation in athletes. As you can see, it breaks down findings into normal, borderline, always abnormal ECG findings. And I would say very much worth learning or having close by if you're doing any sort of pre-participation ECG screening. Here, I'll also plug the University of Washington ECG interpretation course. Many of us AMSSM members are likely already aware, but this is a free resource you can access through the AMSSM website and through their own website. It's extremely helpful in getting comfortable to quickly assess ECGs in athletes. It has also helped my general ECG interpretation skills in family medicine residency, so a worthwhile investment in my opinion. And then if you want a lecture format, there's also Dr. Dresner's presentation given a few years back through the AMSSM online fellow lecture series, if you want another great free resource. This paper delved briefly into PEDs, and I won't spend much time here. Overall, evidence is lacking for obvious reasons, but anabolic androgenic steroids are the most studied. DeAndrea and others found that anabolic androgenic steroids are associated with subclinical systolic and diastolic dysfunction. One of the key takeaways from their paper, though, was the strong association with the dose and duration of the drug use. But the clinical relevance is still up for discussion, and more work needs to be done there. This paper also discusses gray zone cardiac morphology. Hopefully you've seen through this presentation that there's obviously going to be overlap between normal adaptation and pathology. I think a key takeaway and that they highlight in this paper is to always consider your pretest probability. So symptomatic patients and those with a family history of inherited cardiac conditions are obviously much higher risk and should be treated differently. Things like echo and cardiac MRI are some of the first line advanced imaging that you may go for. But as always, shared decision-making and multidisciplinary approach with cardiology, et cetera, is usually best. Again, this is a whole presentation in and of itself, but hopefully this presentation serves as a little bit of a primer to then understand some of the pathology. Here, I'd also like to plug the ORCA study. You may have seen this at the annual meeting or on the AMSSM website. This is a large ongoing registry looking at cardiac conditions in athletes, and it stands for Outcomes Registry for Cardiac Conditions in Athletes. And you have the ability to register yourself or a patient athlete, and that can be found through the AMSSM website. Given we have been talking about all these cardiac adaptations exercise, I think the question of too much exercise logically flows next. We typically link exercise to all of these typical benefits, but is there concern for any pathology that could result from any of the adaptations we've discussed. Well, it's an area of ongoing research, of course. It's been thought that exercise training volume was curvilinear in its benefits, meaning that we get continued health benefit with increasing volume without much downside. However, the American Heart Association and others have theorized that there may be some growing evidence that at the highest levels of exercise, we may actually see some partial loss of the health benefits, where the curve maybe looks more like a reverse J shape shown on the right-hand side there. Some of these maladaptations, as we'll call them, include things like atrial fibrillation, coronary artery calcification, and myocardial fibrosis. Atrial fibrillation in particular has been relatively well documented in the literature. The graph on the right-hand side here it illustrates how as training volume rises, the relative risk for AFib tends to rise up slightly above baseline at the highest levels of exercise volume. And again, this is an ongoing area of research, but definitely something to consider. The last thing I wanted to touch upon briefly was the topic of female athletes. This is a traditionally understudied population in sports cardiology. The NFL, NBA, MLB all have significant funding and notable research arms, but sometimes the same emphasis is not placed on women's sports. Most of the seminal papers in this field and a lot of the ones we have discussed today in this presentation almost exclusively looked at men. So this is definitely an area for improvement within sports medicine and something that can be explored further. With that being said, here are my references, and at this time we can open it up to any questions.
Dr. Newhart, that was a fantastic summary of that paper and just an overall great presentation. So great job in preparing and presenting that. At this time, I'd like to first open it up to Dr. Porter to see if there's any additional comments that you'd like to make before we open it up to any further questions.
Yeah, I want to second that Dr. Newhart did a very good job at taking a very complex review article there and really hitting a lot of the highlights, and then also identifying some areas that can be explored in the future, and to continue to expand our knowledge so we can provide better care.
Okay, great. I don't currently see any questions in the chat, but certainly if anybody on the call has any questions they'd like to propose, please feel free to do so now.
Hamilton, I'll throw one at you. So when you mentioned in your talk the whole idea of you said, of course, shared decision making, but I would say that when I went through my training, that was not something that we really regularly considered for cardiac abnormalities that are picked up. So can you just talk a little bit about what your training has been like as it relates to, you know, when you identify someone with an abnormal ECG, and what's the next step as it relates to talking with the patient?
Yeah, I mean, I think there's actually, I'm on a sports medicine elective today, and we actually had a patient that had hypertrophic obstructive cardiomyopathy that had an arrest and had an ICD placed. And so, you know, he was previously a top track athlete. I think he was 6th in the nation in the 200 meter for juniors. And you know, I think me and my attending and I, whenever we were talking to them, the father was very hopeful, you know, about potentially getting him back out there, and the athlete himself was pretty excited. And so, you know, I think it's definitely was highlighted to me by the attending I was working with that, you know, it is a shared decision-making process. You know, it's the patient and the family have to be comfortable accepting the risk that comes with it. And then obviously the physician also has to be comfortable. But even in my family medicine training, you know, there's many situations day to day where, you know, we're implementing shared decision making for borderline cases. You know, do we start a blood pressure medicine? Do we start a statin? You know, all of this, you know, there's gray zones there, and sometimes there's definitely a lot of back and forth between the patient and me and in those discussions.
Hi there, guys. Good evening. My name is John. Dr. Newhart, thank you for that interesting presentation. My question now is, you've categorized both sports into isotonic and isometric, right, depending on the sport. but I believe there are certain rising mixed hybrid of sports, i.e. CrossFit, martial arts. Is it possible that a sport can exist both isometric and isotonic stresses to the heart?
Oh yeah, for sure. I think that I can go back and pull that up. Back here on this slide from the American Heart Association, they actually classify sports, and so I'll pull out the laser here. On the bottom part here, you can see they call it dynamic here, but it's more akin. It's akin to isotonic stress is kind of what that means, and then you have the static component, which is more corresponding to isometric, and you have things like boxing, rowing, speed skating, things that are a hybrid of both, that are high in isotonic and high in isometric. So definitely, sports like up in this category, we have American football is a 2B, so it's kind of moderate and on both categories, and so there's definitely a lot of overlap. I think for educational purposes, we kind of try to isolate things to make it easier to talk about, but there is quite a bit of overlap, of course.
Thank you for that explanation. I was looking for tag here, but thanks.
Oh,
Okay, well, if there aren't any other questions or comments, we can move on to our second presentation for the evening. So I have the pleasure of introducing our second presenter, Dr. Matthew Mayeda, and his co-club mentors, Dr. Stanley Herring and Dr. Margot Putukian, who are both really giants in the field of sports medicine, and really both don't need an introduction, but we will certainly go through this nonetheless. They are both the primary authors for the article that Dr. Mayeda is going to be presenting tonight. So Dr. Mayeda is a third-year resident at the Santa Rosa Family Medicine Residency Program in Santa Rosa, California. As a prior competitive gymnast and hip-hop dancer and current co-chair of the residency's diversity work group, Dr. Mayeda is passionate about empowering underserved communities through sports medicine. His most recent works included co-leading the AMSSM CRN breakout session on health inequality and research entitled Finding Diversity, Inclusion, and Equity in Sports Medicine Fellowships, a regional review of U.S. program websites. His presentation is on the article, Team Physician Consensus Statement, the 2013 update. I'd also like to thank Dr. Stan Herring and Margot Putukian for serving as the co-club mentors. Dr. Stan Herring is a board-certified physical medicine rehabilitation physician who has been in practice for over 40 years. He is a clinical professor in the Department of Rehabilitation Medicine, Orthopedics and Sports Medicine, and Neurologic Surgery at the University of Washington. Go Huskies for tonight. Dr. Herring holds the Zachary Leadstedt Sports Concussion Endowed Chair. Dr. Herring is a co-founder of the Sports Institute at University of Washington Medicine, where he serves as a senior medical advisor and also serves as the co-medical director of the University of Washington Medicine Sports Concussion Program. He is co-medical director of the University of Washington Medicine, Orthopedic Health, and Sports Medicine, and is one of the team physicians for the Seattle Mariners. He formerly held the same position for many years for the Seattle Seahawks. Dr. Herring's practice focuses on the diagnosis and management of neurologic and musculoskeletal injuries, particularly focusing on spinal disorders in active people and athletes, as well as sports-related concussions. He has also held many national leadership positions, including president of the North American Spine Society, member of the Board of Trustees of the American College of Sports Medicine, and is the board member of the Foundation for Physical Medicine Rehabilitation. He is also one of the founders of the American Medical Society for Sports Medicine and is a founding member of the Physiatric Association of Sports, Spine, and Occupational Rehabilitation. Dr. Herring has been on the editorial board of professional journals and is an editor of 9 textbooks, as well as an author of 117 peer-reviewed journal articles and 55 textbook chapters. He was a major contributor to the successful passage of the Zachary Leadstedt Law in Washington State, and his continued efforts helped pass similar youth concussion legislations in all 50 states in the District of Columbia. In addition, he is a frequent national and international speaker on a variety of physiatric and sports medicine topics. He has been recognized for his career's work as a recipient of the Frank Cruzen Lifetime Achievement Award, the highest honor given by the American Academy of Physical Medicine and Rehabilitation. Now transitioning to Dr. Putukian, she's the Chief Medical Officer for the Major League Soccer and team physician for the U.S. Women's National Soccer Team. She's a past president of the American Medical Society for Sports Medicine and has served as the Director of Athletic Medicine and the head team physician at Princeton University. She has served as a U.S. OPC team physician for the Beijing Olympics in 2002 and will be serving as a U.S. OPC team physician at the Paris Olympics in 2024. She's also served as a U.S. men's national lacrosse team physician team position from 2010 to 2018 for the World Cup champions and for the World Cup champions in 2018. She received her BS degree from Yale University, where she played soccer and lacrosse. She is board certified in internal medicine and also has a subspecialty certification in sports medicine. She has served as a senior advisor for the NFL Head, Neck, and Spine Committee and on the NFL General Medical Committee. Dr. Putukian has also served on the U.S. Soccer Medical Committee, as well as the IOC Medical Health Work Group and US OPC Mental Health Task Force, and the NOC SAE Scientific Advisory Committee, and has served as an advisor on concussion for the CDC and on the FA Research Task Force. She was also the former chair for the USA Lacrosse Sport Science and Safety Committee. She is the co-author on several team position consistent statements, AMSSM position statements on concussion, mental health, mononucleosis, and on the IOC mental health and elite athlete statement. She is the editor for the Netter Sports Medicine textbook, as well as involved in concussion research, and has authored over 150 peer-reviewed publications, more than 60 books chapters, and has given more than 240 regional, national, or international presentations. She is an invited expert and co-author for the Zurich, Berlin, and Amsterdam concussion and sport conferences. Without further ado, Dr. Mayeda, I'll hand it over to you now.
Awesome. Thank you so much for that introduction. Once again, my name is Matthew Mayeda. I'm a third-year resident at the Sutter Santa Rosa Family Medicine Residency, which is associated with UCSF. And I have the pleasure of presenting Team Physician Consensus Statement 2013 Update. I have no disclosures. And I really want to thank my club mentors and primary authors, Dr. Putukian and Dr. Herring, who are here today. They offered amazing insights and provided this amazing resource, which is really helpful for all those interested in sports medicine. I also want to thank our moderator, Dr. Romero, the coordinator of this event, Joan, and then you all as attendees for attending this event. Thank you so much for your time today. When I first met with my mentors, they asked me why this paper. I chose to do this paper because I really believe that team physicians are vital to athlete success. I was, as mentioned, a gymnast, martial artist that turned into a hip hop dancer only because I had amazing physicians that were able to help me overcome compression fractures, torn ACLs, and without them would not have had many fun experiences in hip hop dancing as I did later on. So becoming a really good team physician takes a lot of different processes. And so this is the objective of today's talk, is that we'll kind of understand the purpose of this consensus statement. We will kind of talk about the different categories and components of a team physician. I'll share some of the resources about how to strengthen that care of athletes, and then we'll talk about considering possible updates. This is the outline that we'll be using to kind of achieve those objectives. And then just as a heads up, the original text is included in many of the slides as a reference. So I know it's a little bit text heavy, but I think it'll be great in case there are questions later on. So to start with our introduction, let's talk about the consensus statement goal, which they center around really ensuring the best medical care for the athlete by a team physician. So it's really, really patient or athlete centered. And to do this, they break it down into kind of three different parts: qualifications, duties, and responsibilities of this team physician. They also want this consensus statement to serve as guidelines of individuals and organizations in electing this team physician, and then providing foundations for best practices in medical care of athletes and teams. They do note that this is not intended to be a standard of care and should definitely not be interpreted as such. So you notice that it says 2013 update. So that is an update to the 2000 original statement, and new sections included were ethical and medico-legal issues. And then when talking to the authors about this kind of amazing statement, I asked like kind of what their personal goals were with it, and they were talking about the importance of making it a very usable resource, both in utility and applicability to a broad range of populations. Obviously, they have a lot of professional experience, but it's a great resource for all levels of sports care. And so I think with that, it's really nice that it's really relevant. And as we'll discuss today, medicine itself is a uniquely challenging field. And then when you add sports to that, It's quite the complex maze to get through. So let's start with the background. What exactly is a team physician? I kind of summarized this into 3 different parts. The original text is below, but a summary statement I came up with for the first part was a physician leader in the organization, management, and provision of medical care for all athletes. So a physician being an MD or DO, really being a leader within those 3 aspects, which are really different if you think about it: organizing, management, and then actually providing the medical care for all athletes at all levels of events, but be that an individual, team, a mass participation sport events. And so that's a lot of different people and things. And then the specialty within that definitely is the MSK part. So my summary of these kind of next 3 parts was a medical expert in MSK injuries and medical conditions encountered in sport that works with interdisciplinary teams to educate athletes, coaches, parents, guardians, and administrators. So not just our athletes, but expanding to the interdisciplinary team that takes care of them, as well as their support systems. Last, I did want to highlight, and I think they do a good job highlighting this as well, is like really that important responsibility of ultimately being responsible for clearance to participate and return to play for our athletes. So that's the team physician. Let's talk a little bit about the consensus statement itself. Who is building consensus? It is the 6 major organizations you see here: the double AFP, AAOS, ACSM, AMSSM, as well as the American Orthopedic Society for Sports Medicine and the American Osteopathic Association of Sports Medicine. And so there's an entire method built around this, and they do a really great job of outlining it within, especially their latest one on concussions. But it's really done through this Team Physician Consensus Conference, which is formed to create relevant, timely, and condensed resources specifically for team physicians, working with every level of competition. There are typically 2 representatives from each of those 6 professional medical organizations that read all of the existing literature to develop outlines, which are then kind of refined by that team of the consensus conference. And then they deem things as essential or desirable information for the team physician. I really, really like this essential and desirable kind of statements. It's kind of also what I do for goal setting with my own patients. I think it's really important to understand, what is essential, what is the floor, what is the must-haves, but also why not shoot for the stars? Knowing what is desirable, the ceiling, or what we're really shooting for in ideal situations, I think is also really important. And the method that they went about for categorizing the role of the team physician was broken down into the categories of medical qualifications and education, medical duties and responsibilities, administrative duties and responsibilities, ethical issues, medical legal issues, resources. Then they provide some suggested readings. And so we will jump into the results of each of those sections now, starting with medical qualifications and education. So starting with the essentials, and then we'll go to the desirable. This needs to be an unrestricted license to practice medicine with a MD or DO degree. And it is really essential to kind of have these like fundamental knowledge of on the field medical care, basic cardiopulmonary resuscitation with automated or AICDs, and then a working knowledge of MSK injuries, medical conditions, and psych issues which affect athletes. But if we're talking about what is really desired, having kind of a specialty board certification, and a lot of it isn't really like just knowing, but really I think doing sports medicine as a significant part of one's practice, which would include also getting continued medical education, participating within those societies that were mentioned before, teaching, researching, publications are all important, not just knowing basic, but knowing our advanced life supports. And then also having a interesting aspects of things that go beyond the actual medical care, whether or not that's like disability, workers' compensation, or even social media training. In terms of the medical duties and responsibilities that are outlined, the essentials really stand along the game day So having that chief of command for injuries and illness management, coordinating that game day, understanding kind of the importance of who gets to play for that game, recognizing and understanding the issues that kind of affect all athletes, and then the unique issues that affect specific populations, whether those are older, younger athletes, or other different defined populations, and then kind of integrating within that medical expertise. The desirable duties and responsibilities, though, is really being up to date with kind of the latest and greatest. So kind of those consistent statements. And really, I think what defines this desirable category is going beyond the actual game day, providing the care in between, preventing injuries before the game day happens, not just recognizing, but actually addressing those various issues that affect many athletes' performances, and then addressing the unique issues within each of those specialized subpopulations. And then also not just focusing on athletes, but their entire kind of athlete sphere, which includes guardians, coaches, and administrators. We'll move on to administrative duties and responsibilities. And so the essentials there kind of being aware or involved with the EAP or emergency action plan, and being aware or involved with the sideline and event preparedness. Also being involved with a team physician and the organizing body. So really kind of those like essentials, needs, must-happens of the day-to-day. But when we talk about what is desirable, it's really seeing not just like participating within, but actually developing and implementing these emergency action plans, not just knowing, but actually having written agreements outlining the medical and administrative responsibilities, which will be talked about a little later, how important it is, especially with the medical, legal, and ethical issues. And then also educating, again, beyond just the athletes, those guardians, administrators, coaches, and other interested parties that could definitely exist. Within ethical issues, there are ethical issues for all physicians, but they do a great job pointing out about the specific unique challenges within sports medicine. So being not just familiar with the medicine part, but also the ethical issues that come up with practicing sports medicine. So confidentiality, day to day, we're not supposed to share health information, but drug testing results come into fair play, and how does that information then get shared? Getting informed consent, especially, for example, in occasions or locations, when you're in the middle of a really time-sensitive sports situation, is quite complicated. Having an awareness of like conflict of interest, financial relationships with industry or teams. There's a lot of third parties, especially with sports, whether that's parents, coaches, social media, larger corporations. And with those pressures come potentially the pressures of performance-enhancing drugs, and payments, whether or not that is payments to be a team physician or other sorts of advertising, marketing, and publicity parts. And then also there's always new products and technology, but whether or not they're actually evidenced for efficacy or safety is sometimes hard to know, but especially at high level of sports play, the pressure and that difference of a little bit of an advantage sometimes can be the difference between first and second place. So quite complicated ethical issues. What I think is really nice here, though, is that they also provide solutions. So really the key being patient-centered, focusing what is best for the patient and only on the patient will provide really good, I think, clarity in what one should really be doing, as well as providing like early transparency. So right at the get-go, from any of the relationships that are being built with any of the parties, be it athlete, guardian, the organization, that you disclosing and managing kind of any potential conflicts and understanding everyone's different relationships. The second part that was new to the statement was the medical legal issues, which again are unique to sports medicine and not just the physicians generally. So a lot of times we're talking about schools, and so there are different privacy laws even actually with schools, not just healthcare organizations versus HIPAA. Schools are FERPA. Decisions evaluating management significant on-the-field injuries and illnesses. And so I do think that we see quite a bit of these different kind of conflict of interests that can become legal issues. And then, of course, the ever intense medical record documentation and kind of the different challenges of doing both that while a sport is coming is something that I've also seen kind of in day-to-day practice. All right. And so that was a lot of information and a lot of different things. So what to do if there is an area of potential weakness or area desired growth from getting from that essential to that desirable team physician to provide that best care is that they provide resources. So that knowledge is power. There's 27 articles of diverse topics that are included that I highly recommend individuals look over. They have range from ethics, heart illness, secondary school, to name a few, but really kind of leveling up as a team physician. All right, we'll go into the discussion part. So limitations, which I think aren't necessarily fully limitations, but important things to recognize. The landscape of healthcare and sports does change over time, right? From 2000 to 2013, there were more issues with like medical legal and ethics. And so the role of the team physician changes kind of with these landscape changes. And that's why these updates occur. There also are, this is not like a systemic review. So I know a lot of these journal articles, there's like p-values and things like that. And this is not a standard of care as mentioned before, but it's not intended to be. I think a lot about kind of that public health training and internal versus external validity. I think this is a very usable guide, and it's based on a lot of really great literature, but it's not necessarily a systemic review. So future considerations of landscape changes that kind of I discussed with the primary authors range from changes in autonomy, that shared decision making that was talked in our prior lecture, which was excellent. Emergency action plans, those written plans of care, second opinions, clearance decisions, specialty decisions, and then kind of your ideas. So I think can be a great thing to kind of brainstorm. As mentioned earlier, for example, a lot of my work goes around with like health equity. And so considering like maybe how that could be built in to this as it seems like an area of growth based on this last year's kind of research symposium. But in conclusion, there are a lot of components to being a team physician that is able to provide the best care for athletes. But luckily, there's this consensus statement that both delineates essential and desirable components required for the team physician and provides the resources to help everyone get to that desirable status. And you all should stay tuned. There are new consensus statements newly released and those to come, MSK injury, mass participation, return to play, and then there's actually should be working, I believe, on a new team physician consensus statement. So here are my references, and then time for our group discussion. That's my contact information, but if you're so interested, you could leave in the chat what you think is the most important aspect of the current statement or something that you'd like to see added. Thanks so much.
Again, great presentation and great summary of that article. I think you did a fantastic job with that. I'd like to go ahead and open it up to Dr. Putukian and Dr. Herring and see if they'd like to, if they have any additional insights or any additional points they'd like to make.
Well, I will defer to Dr. Herring since he's the main spearhead of this whole process in terms of the TPCCs. But Matthew, you did a great job.
I guess we'll go in order of increasing competency. So I'll talk first, Margot, and then you can add something of relevance later. Yeah, great job, Matt. And Matt, your personal interest in this is reflected. Many physicians who want to be team physicians themselves were athletes. And as your background and your video demonstrated, you fall into that category. That's often seductive, because you like the sport, right? And then there's honor and glory about being designated a team physician. And sometimes that does cloud your ability to critically think about what you're agreeing to do. And the consensus, this consensus paper that we wrote really asked for you to pause and think not only about the fun part, you know, the playoffs and the ability to be on the sideline or on the pitch, but to think about what your role is. It's an interesting role for a physician to be a team physician because unlike your office or the hospital, you're not really in charge here. It's not about you, it's about the event. And that does force you to think critically about how you do your job, how you have an understanding. So the idea that we emphasize, you know, the whole idea of an EAP, early planning, rules and responsibilities, what the coach should know, what you should know. It's fun to be there. You're not there as a fan though. So I think it's really helpful, Margot, to see young physicians think about this now, not after you're already in the position. So I compliment you on your interest in this paper. And as far as the process goes, Matt, you are right. We work diligently. We do ask the authors to do a literature search, but what this is intentionally is not a systematic review. This is a paper which we hope that will be read the way you read it, a practical guideline for someone like yourself who wants to think about the definition, duties, and responsibilities of a team physician. And we added the ethics and the medical legal issues for a reason. They are more relevant than ever. What do you think, Dr. Putukian?
Yeah, no, I think, you know, I was involved in my first team physician consensus statement was back in early 2000s, one of the first return to play ones, which has morphed and now is called return to sport. But I think one of the things that I have found the most rewarding is, you know, being involved in this process. And as you mentioned, you know, the essentials, desirables, I think it's a really nice framework, because it's one of those things where, you know, if you're in the middle of nowhere, what's the expectation that if you're going to be a team doc, if you're going to call yourself a team physician, what are the expectations that are essential for you to know? And then, you know, as Stan always says, you know, desirables are like world peace, right?
Yeah, whatever you want.
Which would be pretty admirable right now.
Yeah.
And in this particular document, this is the reason the TPCC started, was defining the team doctor. And obviously it's gone through a lot of iterations, and you know, we're in the process. We're going to meet in a couple of weeks, and we have our delegates. They've been given their homework. They've all pretty much turned their homework in. And the things that we're emphasizing are some of the things that we started to talk about, but you know, reflect literally the earlier presentation in terms of shared decision making. You know, athletes with disabilities, mental health. What is it when we say elite athletes? What do we mean by that? Like defining that, and then also dealing with some, you know, additional issues like, you know, what about social media? What about NIL? You know, what about traveling or violence and safety? And, you know, sort of really expounding on some of the ethical and medical legal things that our doctors are facing, you know, as team physicians, right? Like the malpractice stuff. And so there's a lot of issues related to clearance, expert testimony, second, third opinions that are evolved, and definitely evolved since the first time. So, yeah, I mean, I think for me, it's been incredibly rewarding to be involved in a lot of the TPCCs with Stan and Ben Kibler, and now we have Lance LeClaire. But they really do speak to sort of some of the issues that any of us that are working as team doctors should be thinking about when we're taking on that role.
You know, when you're training and you're working with your attendings, your team physicians, you should ask them about the hard parts of the job.
Right.
You know, they should mentor you as to what skill set they need and how the challenges of this job particularly affect them. And it pretty much, as Margot said, there's plenty of elite athletes who are 12 years old now. I'm not talking just professional sports, but elite sports, and those issues with coaches, owners, parents, you know, and so it's important work, but I think it's important work for physicians to maintain professionalism and to offer something which not necessarily is always pleasant. Sometimes you have to protect the athlete from themselves. Anybody here who's an athlete knows that. But it is a unique opportunity to demonstrate the practice of high quality sports medicine in a different environment. And there is risk involved. And everybody says they want to be a team doctor, but I would counsel you to be patient and not jump into covering something until you're ready.
I mean, I think one of the other things that is if you're gonna, you know, if you're asked, it doesn't matter what level, but let's say you're asked to be, you know, covering a high school football game. Make sure you know what the guidelines are, and are you going to be able to make that final say? You know, are you going to have is the medical decision going to be yours as to whether an athlete should return to play or not? Because if it's not, you know, if that hasn't been sorted out ahead of time, you can find yourself in a little bit of a pickle. So.
Yeah, the coverage itself is really the last piece of this.
Mm-hmm.
I mean, all those things need to be established long before. And if you say I'm going to cover a high school game, then all of a sudden you're sort of responsible for whatever emergencies happen. And if you don't have an EAP, which is well described and practiced, and there's not a medical timeout, that's kind of on you, even if you're a volunteer physician. So the game is the last 1 hour of a year-long process. And I think you'll see that emphasized much more, Matt, in our updated consensus paper on this topic.
I'm going to ask a leading question, Matt. As you reviewed this, are there areas that you sort of see as sort of like, man, they didn't really touch on this at all, and you know that you're experiencing in your setting currently that aren't addressed well enough in this statement?
I guess we all have our different things. So I do a lot of my focus too on like health equity work. And so I think that was like something that was really interesting at the last AMSSM kind of research summit, is that like sports medicine, you know, it's like such a great area actually that is quite a bit more diverse than a lot of different areas of medicine, especially with patient population. But it's interesting that it doesn't that there actually isn't that much research within the areas. I think that there were like 0 research articles they found about like language spoken and like sports participation, for example. And so like half of my patient population speaks Spanish. And so I think sports physicians could potentially play a increased role in kind of making sure that like we want to treat all of our athletes really well, but making sure that we're aware of like which athletes might maybe be facing additional like socioeconomic status challenges that would make them at higher risk for, especially when we're talking about maybe even the different components of health, like psychological wellness, or ensuring that like, you know, do they have the same safety equipment as other players? So just like, I think a lot of times that SES stuff isn't looked as much at, but I think similar to how in normal healthcare, it's like something like 70% of actual health is outside of actual healthcare. There's probably a lot of our athlete health that's actually outside healthcare that would be helpful for physicians at least at a desirable level to be aware of, so that everything goes well for their athletes.
Yeah, Margaret, I think this is
Thanks.
good and it's current. You know, Matt, you find yourself in a position, as I said, as though you don't really have all authority here. It's about the game, right? But you're there as a healthcare provider, and you need to be cognizant of the culture of the sport. You know, nothing worse than a doctor telling a coach how to run his team. That always goes over well. You know, that's always popular. But if you gain the trust of the coach, then she or he does look at you, and you can institute change by example, right? And by demonstrating that it might be helpful if an athlete understood instructions in her native language. And you can couch that Matthew, that if coaches and teams do this, they will win more. It's all about winning. So you can use that to say this is, I mean, the intrinsic value to us as healthcare providers, it doesn't need to be emphasized, but once again, look at the culture where you're working. And I found out that, coaches are more interested in proper concussion management if they think they'll lose less games if they do it.
Yeah, I think the other area too, though, is, I mean, and again, it reflects back on the previous discussion that we had with the other paper, is when you're, if you're a team doctor and let's say you have a EKG abnormality, there are some situations where parents, players may not end up getting that, if they're told they need an echo because there was an abnormality picked up on their ECG, everything's fine, but we just need to do this echo to make sure it's okay to participate. There are some situations where that parent or that kid might be like, and we can't afford it. So guess what? You're not gonna, little Janie isn't gonna play sports anymore. So I think that's really an important area, and I'm sure I know we'll be discussing it in the next TPC. So thank you for that. That's a great point.
Well, we'll channel your inner hip hop energy, Matthew, to make sure that we address that coming forward.
Well, we appreciate the great discussion there. That certainly is. We appreciate each of your insights, and again, great presentation there. But I'd really like to thank Dr. Newhart and Dr. Mayeda for taking the time to choose articles and then create presentations for tonight. I also want to thank each club mentor. So thank you, Dr. Porter, Dr. Herring, and Dr. Putukian for all of your efforts and insights for tonight. And also like to thank all of the attendees for tuning in tonight. We have 2 more journal clubs for the rest of this month. So we have an additional meeting tomorrow night at 8:30 Eastern time for 3 presentations. And then our next journal club is going to be on Tuesday, January 16th at 8:30 p.m. Eastern time. And we also have 3 presentations that night. We look forward to having you join us for these presentations both tomorrow night and then next January, on January 16th. And with that, we'll go ahead and conclude tonight's meeting. Thank you all for tuning in.